Thank you very much indeed for the chance to speak. I'm an anaesthesiologist and critical care doctor in London, in England, and up until about going back to work there about 20 years ago, I was on staff at Duke University Medical Centre, so I've worked in both systems, albeit my US experience was a little while ago. And you've got my titles there. I'm a professor at the university as well. The bottom bit is the bit I'm going to be referring to. I was lucky enough for 4 years working for the Department of Health in England to be a national clinical lead for the Enhanced Recovery Partnership Programme. And I'll try and explain that journey. It was a spread and adoption quality improvement programme where we tried to implement enhanced recovery in 4 major surgical areas through the whole country of England. I was appointed as a national clinical lead alongside a surgical colleague. That's Alan Horgan, who's a colorectal surgeon from Newcastle, who'd already implemented successfully an enhanced recovery programme. I have some disclosures, which includes being sponsored to be here at the moment, and the fact that my chair is sponsored by UCL with an unrestricted grant from Smiths Medical. I run some educational meetings. I'm on the board of some journals. I'm editor-in-chief of Perioperative Medicine, that's been referred to a few times. The most important one is probably at the bottom, is the fact that for my work at the Department of Health, they backfilled my salary for 1 day a week to perform this role for 4 years. Now, just to say a little bit about the National Health Service, which not all of you may be familiar with. It's a health service that's provided out of taxation. It serves all of the people in the United Kingdom. It's free at point of use. And at peak expenditure, we were expending about 8% of our GDP on healthcare, including the 15% of people that also carry private insurance. But almost everyone works in and uses the National Health Service, alongside some private clinics as well. This is a picture of some of my colleagues taken in 2007 on the summit of Mount Everest. Alongside my clinical work, etc., I'm lucky enough to be a part of a human physiology group that does high altitude research. I was further down the mountain at the stage at about 3,500 meters running a laboratory, and we went back again last year, so I spent 6 months in the field. The reason I show this is not just to advertise that we've got quite a wacky group at UCL, is that what you have here is you have 3 clinicians. You have an anaesthesiologist, critical care doc, you have a surgeon, and you have a community practitioner stroke internist. And they can work very, very effectively together, following clear guidance and guidelines to get to the summit of Mount Everest safely and back again. You tell me there's 3 major rules, apart from do as you're told. That's as if there's a good rope, clip onto it. If you have oxygen, use it, and don't eat the yellow snow, which I'm sure makes sense to some of you. So, interesting, when they come back from these endeavours, these are very, very challenging logistical exercises. We take 250 people at a time out to the Everest region and millions of bits of equipment. A recurring theme when they get back is, why is it easier to get doctors to the top of Mount Everest than it is to change their clinical practice? Get those 3 guys in a room to agree on the implementation of clinical pathways. It's much harder and seems to take much longer than getting them to the top of a mountain successfully together. And I'll reflect on the end as to why I think that may be. So here's the UK perspective that triggered our quality improvement programme implementing enhanced recovery in the UK. We had a change of government, outgoing government handing over to incoming government, and there's this famous post-it note handover from the outgoing finance government guys to the incoming guys. And you can find this on the internet. It was a post-it note that read simply, "The money is all gone." So we had gone over our fiscal cliff, and in order to make that palatable to the voters who just elected a new coalition government, the message coming out from the politicians was, we're not going to cut health and we're not going to cut education, we're just going to cut everything else. Now that sounded pretty good to begin with from the health perspective, until it turned out that what they really meant was, we're going to freeze your budget. So we're not going to give you any inflationary uplift, we're not going to acknowledge healthcare inflation, we're just going to keep it the way it was back in 2009. So that's effectively a 20% cost pressure, and as of now, from spending 8% of our GDP on healthcare, we're now spending 6% of our GDP on healthcare. Mixed in with that, they promised the voters that they would provide ever-increasing quantity and quality of healthcare, but we, the providers, would do it at reduced cost. Now, according to the World Health Organization, we're one of the most